Okay, I'm going to go ahead and get started with our housekeeping so that we can be on time today. I'm super excited for today's presentation. So we will take care of these and then get on to the good stuff. As usual, we are recording this echo session so that we can post it on the Canvas page. So by participating in this session, you are consenting to be recorded. If at any point you would not like to be recorded, you're welcome to disconnect from the Zoom link. If you need to rename your profile, it's helpful to have your first and last name or even your organization so that we know who is attending. If you would like to rename your profile, those instructions are right here. That's pretty quick. Click on the participants icon, which is likely on the bottom of your screen. You can click on your profile and rename your profile in the dialog box. You can raise your hand if you would like, but when we get to the discussion portion of today's session, we will likely just have an open conversation. If at any point you need help renaming your profile or knowing how to raise your hand, feel free to send a message to one of our hub team members and we will help you do that. As a reminder, because we discuss case scenarios and often share information about our experiences, when you're sharing information about another person, avoid using their first, middle, or last name or any initials. We don't want to provide any identifying information, anything about family members, friends, coworkers, email addresses. So de-identify your examples and discussions as much as you can. If you're unsure about whether or not you should include a specific part of information, and you can send one of our hub team members a message and we can help you figure that out. If you haven't been to one of our echo sessions before, this is an interactive community where we expect everyone to participate in discussion. We'll start with a didactic presentation and then a group discussion. Depending on how many people are here today, we'll either have breakout groups or we'll have one group discussion based on our case scenario. So participants are encouraged to be engaged in asking questions and providing feedback for the case scenario. These case narratives are the best way to apply the skills that we learned during the didactic portion. We're always looking for case scenarios. So if you have something that you would like to discuss, an ongoing case, reach out to us and we'd be happy to work that into a future session. As I mentioned, we'll have a didactic speaker and then a case presentation. This is intended to be a community of practice style meeting where we are sharing knowledge and working through issues together so that you can leave this with information to apply to your work setting. And once again, if you have a case study that you would like to work through, you can send us an email at mhidd@aggies.usu.edu and we can get that set up. We do offer certificates of attendance as well as Utah Social Work Association continuing education units. If you would like either of those, you'll need to be sure to fill out our survey. And I will drop that link in the chat a few times throughout the meeting today so you can access that. At the end of that survey, there's a multiple choice question. You can select whether you want a certificate of attendance or a CEU or both. I'm happy to do either or both for you. We do have a Canvas page. That's where we upload the recording from these meetings. It's also where I will upload the case scenario information and I will summarize the recommendations that we put together as a group. So you can access that in the future. If you'd like to register for that, you can send an email to that same email address and I'll drop that in the chat. You can request that you're added to that page so you can have access to all the materials. We do have social media. So if you're interested in learning more about other ECHO projects that are going on here at the IDRPP or about future presentations for this ECHO, you can follow us on Facebook or Instagram. This QR code will take you there. Our next session will be September 11th. That will be a part 2 in the evidence-based approaches to providing mental health services for adults with IDD series. And today, I'm so excited. We have Debbie Bilder. I do have some information here, and then I will let Debbie add anything she'd like to add. So Debbie is a professor in the Department of Psychiatry in the Division of Child and Adolescent Psychiatry at the University of Utah. She also holds adjunct appointments in the departments of pediatrics and educational psychology. Following her residency, she participated in the Utah Regional Leadership, Education, and Neurodevelopmental and Related Disabilities, otherwise known as URLEND, that some of you might be familiar with, and she is now a consultant for that program as well. Through her leadership, she's facilitated the growth of the Neurobehavior Home Program, a fiscally viable Medicaid-funded subspecialty medical home program for individuals throughout the lifespan with neurodevelopmental disabilities. She's a clinical and research expert in autism and is the principal investigator for the Utah Registry of Autism and Developmental Disabilities and co-principal investigator for the Utah site of the Centers for Disease Control and Prevention's Autism and Developmental Disabilities Monitoring Network. So Debbie, I'll let you take it away. Feel free to add any other introduction elements that I might have missed.
No, I think you got everything. Thank you. And thank you for such a nice introduction. Let me go ahead and share the screen and then I'll move. Oh, great. So, so I can share that. Okay, I'm going to put this here. So, and you can you guys see the screen? Yes. Okay. With the hand raising, I have trouble chewing gum and walking straight at the same time, and so I'll be focused on looking at the slides. So rather than raise your hand, if it's okay, if you can really just go ahead and unmute yourself and ask the question, or if Rachel thinks it might be less chaotic, Rachel, if you could kind of be, if you could kind of be in charge of, that, to let me know when someone's hand is raised and to answer, to give me a chance for them to ask a question and for me to answer it. Is that okay with you, Rachel?
Yeah, absolutely. Feel free to mute, and I'll also keep an eye out for any raised hands.
Okay, great. So what I'm going to be talking about is establishing treatment targets for agitation, and a tool that my team developed and I use to simplify that process. Okay, these are my disclosures. The only thing related to this talk is that I'll be talking about the sources of distress, which is owned. Oh, I should have put this up there. It is owned by the University of Utah, because everything I do and produce is owned by the University of Utah. But I am also a founder of a small company which isn't doing anything right now, but was established to create a much broader tool that providers could use. So just as part of that disclosure. So we're going to be talking about a person-centered approach to treating agitation, and inherently that means understanding the cause of the agitation, and so talking about common causes of that in individuals with neurodevelopmental disabilities and how to identify these and target treatment, and then just the use of the sources of distress to kind of simplify this process. And by the way, the sources of distress is freely available through the Utah Department of Health and Human Services Autism Services website. So just starting off with evidence-based treatment of agitation, there are medications that have FDA approval to treat short-term agitation in individuals with autism. And there are also other meds that have been shown to be effective in short-term treatment of agitation. And yet this is not the approach that I recommend by any means for the long-term use. For the short-term use, absolutely, we need to ensure individual is safe to themselves and others, but that should definitely not be the end, rather just the beginning of understanding what's going on, so that it truly is used in the short term, unless it's really indicated for a long-term use that you would have in a neurotypical individual. Otherwise, I don't feel that it's appropriate to treat long-term agitation with an antipsychotic. So rather, I really recommend more of a person-centered approach. And I'm a professor here at the University of Utah with, my main appointment in psychiatry. I have an adjunct appointment in pediatrics. I have another adjunct appointment in educational psychology. So I know it's weird to kind of skew from evidence-based, treatment for agitation to something else, but I just feel that that the needs of these folks are often overlooked when evidence supports just chasing agitation rather than figuring out why they're upset. So the person-centered approach that we'll be talking about is identifying what's going on and addressing that. And of course, you could start by asking the patient what's upsetting him or her, and many individuals can use their words to explain that. And yet for those with neurodevelopmental disabilities, many do have impairment with their ability to use words to describe what's going on, particularly when they're distressed. And so in that regard, it's important to look at the behavior itself as well as what other behaviors are accompanying it, as behavior is a way that we all communicate. It's just with this population, the communication is exclusively through behavior. So how could it be communicating things that are important for us to understand, like pain or sadness or anxiety or frustration? And then you would then address that source when you're treating the agitation. So you're treating the patient, not the disability. So the whole point of really kind of talking about this particular area is to get beyond diagnostic overshadowing that commonly occurs in individuals who have neurodevelopmental disabilities, in which providers who don't specialize in this area will attribute the behavior or other concerning features to the disability itself, rather than exploring what else could be going on that needs to be addressed. So I find caregivers as translators. I have found through the many years I've been doing this that everything I need to know in figuring out what's going on, or just about everything, they know. They just may not know what it is they know that's relevant to me, or how that fits into how I would start trying to understand what's going on that can be treated. Because as I mentioned, behavior is that primary means of communication. So I really see the parents as that essential translator between those with developmental disabilities with impaired language. So those who have a means of communicating, whether verbally, whether through augmented communication devices. Parent information can be helpful, but it's just augmenting what that individual can communicate. What I'll primarily be talking about are those folks who don't have that capacity to express themselves, either verbally or through an augmentative device. In those regards, I find the parent a particularly valuable translator. And so when I'm trying to understand, well, what can be going on from a mental health perspective that can be leading to this agitation, I find this tool, the DMID, the Diagnostic Manual for Intellectual Disabilities, to be an incredibly useful tool. And this tool, many of you may be aware of, since it's often well recognized in the intellectual disability provider community. I can tell you it's practically unheard of in the autism provider community, and I wish it were far more recognized and understood. But what this tool does is it adapts DSM criteria for mental health conditions for those individuals with intellectual disability, so that you can follow the DSM criteria that we follow in mental health to diagnose and apply it to those with disabilities. I also feel like understanding the ABCs of the behavior, as far as the antecedent, the behavior, and the consequence, is a critical aspect of understanding what can be going on. Of course, understanding what is inadvertently reinforcing the behavior, what's triggering it. But from my perspective, also thinking about the role that mental health conditions can play in the ABCs that are occurring for that person's behavior challenges. So when it comes to medication use, this is a study that we did at the University of Utah for follow-up on individuals with autism who were identified in the mid-'80s. So to get a sense for that, and these were in about over 60% had co-occurring intellectual disability. I think it was around 65%. So these are with autism plus. Any prescription medication, any psychotropic medication was 58%. I put the box in the wrong place. And then any antipsychotic was 35%. And these are folks, this is a epidemiologic study follow-up. And so they're not a clinical sample. And so just getting a sense of what the antipsychotic use is in that group of individuals is pretty high, as well as the other psychotropic medication use. This is the psychiatric medication use among individuals who presented in crisis to my team from 2019 to 2022. That's when we did this data cut. These folks are presenting in mental health, behavioral, emotional crisis. So that is important to understand that context. You can see over 90% are already on psychiatric meds, and nearly 70% are on antipsychotics, though that antipsychotic is not working the way it's supposed to work because they're not calm. We did the source of agitation was not adequately addressed. And they are really struggling. And for those folks, of course, it's particularly important to understand what's causing this agitation. I feel like actually for all individuals with neurodevelopmental disabilities, it's important for understanding what's causing the agitation so that we can reserve the antipsychotic use for those for whom that underlying cause, would be treated with an antipsychotic if they were neurotypical. I'm not, I realize the reality is that's what calms folks, many folks. I just think it's still important to understand what's going on so that can be addressed first. So agitation, developmental disabilities, I feel like everyone has a reason to be agitated. We all do. It's just these causes are left untreated because these folks can't say what's wrong. So what I find is that treatment-resistant severe agitation, which is what the folks who I see when I'm asked to consult, are these, as you can see, the meds, they have been tried on many meds. It's not working. They'll put me in. And what I find is that treatment-resistant severe agitation is actually caused by treatable conditions, but they were unrecognized and untreated. So we're going to talk about what those conditions are and how to figure them out. So agitation, I kind of think of it like the clotting cascade in medicine. It comes from a lot of different things, but there's also a final common pathway. And it has a very broad differential diagnosis. Pain, sleep disturbance, other medical conditions can lead to agitation, psychiatric disorders, which we'll really focus on in particular, stressors in their environment, the behaviors themselves can be inadvertently reinforced. And then, of course, communication challenges leading to tremendous frustration, as well as difficulty helping people understand all the issues above. And all of this can lead to agitation. And when I get involved, it's people have been treatment resistant inherently. And so it's rarely just one of these. Often it's multiple issues because when it remains, of course, for these individuals. And I find that these individuals will suffer alone for a very long time before it gets so bad that others will suffer with them and they'll pull theirs in. So by the time I get pulled in, they've been suffering for a long time. So speaking to the pain part, I just want to speak to people with self-injurious behavior. So about 50%, a little less than 50% of those in that group that I just discussed, the 151 individuals for whom the sources of stress had been completed in that time, also had self-injurious behavior. And what I will often hear from families or other providers is that there's no way that they can be experiencing pain because you should see what they do to themselves. Their behaviors seem immune. They seem immune to pain, and there's just no way this is connected. And I will have to say that with certainty, they are definitely not immune to behavior disturbance as secondary to pain. And in fact, when they're having self-injurious behavior, the first place I look for a source of pain is the area of self-injury. So if they're hitting their head, looking in ears, looking in the mouth, they need to see dental. Do they have sinus issues? Do they have migraines? Like what could be causing that pain? Because it is not unusual where or biting their hand, and then you see as a result of the injury, you've got this infection, and then that's perpetuating it further. I suspect that part of what they're doing is they're trying to release their own endorphins to manage their experience of pain. I don't know because they can't explain that to me. But I just want to say that consider pain in the differential, even particularly actually for those who are self-injurious. And common sources of pain in this population are gut issues, dental issues, particularly given how this gets hidden in our mouth, and how individuals with neurodevelopmental disabilities may struggle with sensory concerns and not welcome a toothbrush in their mouth, and that may not be the battle that family decided to have that day with that individual to get them out the door and get them going to school. Headache, injury, like I said, from the self-injurious behavior itself. And for females, think about menstruation. those who are of reproductive age, as this can be uncomfortable and from a pain perspective as well as alarming. I found that for those who are female and the group that I had consulted on, we'll have to look. I think I put it later on, but I think it's around 40% had menstrual concerns that the parents thought were contributing to the distress that was presenting. So I want to start with sleep. Everyone needs a good night of sleep. Consistent restorative sleep is the foundation for any leap into wellness. If a person is not sleeping, no matter what you're trying to help them with in regards to their behavior or learning in the daytime, you're going to feel like you're chasing your tail, because that is just how the brain restores itself. And I think a good night's sleep is smarter than the best psychiatrist in regards to restoring the brain and getting it towards wellness and stability. I think the other piece of this is that if the person's child is not sleeping, neither will their parents. And if you're trying to implement a behavior plan or any other type of intervention in the home, it's going to be really hard for them to do so when they're not sleeping either. So that's the first part of what I look at. As far as psychiatric conditions, in a non-population-based group, so I think this was recruited from doing in-person assessments in a community, but this community included Boston and Utah. At least 72% of the children had one additional psychiatric condition to their autism, and that included the following. And more than one was particularly common. Also, kind of in the opposite way, if you look at bipolar, early childhood bipolar disorder and psychosis, you will see higher than expected rates of children with autism spectrum disorder in those groups that are identified. It's still not as common as the above conditions, but they are more common than in their neurotypical peers. So that's childhood. This is young adults. So in this group, because I think when you're talking about autism, it's important to talk about those with the co-occurrence of ID, because it kind of characterizes that group with autism. And this group had an 80% co-occurrence with ID. And so these are folks with autism plus, as Cheryl Smith would say. 77% had an additional psychiatric disorder, and you can see obsessive compulsive disorder was high, anxiety was really high, which is of course very true in the pediatric population as well. Depression in the Tourette, and this group looked at chronic disorders. And this is just the follow-up study that I referenced earlier on the individuals identified in the mid-80s here in Utah with autism. We looked at them 25 years later, and you can see the lifetime prevalence is in orange. Almost 70% had one other psychiatric condition. This was using the mini-pass ADD semi-structured caregiver interview, which goes through these different areas of psychiatric disorders. The blue is caregiver reported diagnosis. So you can see all around, primarily the blue tends to be much lower than the rest. Those are the diagnoses the caregiver was aware of. And then these diagnoses in green and then in yellow are the ones which we identified through administering the mini-pass, green being lifetime and orange being current. And once again, anxiety very high. You can see expansive mood, hypomania. Caregivers reported, maybe 8% here. We found about 6% lifetime, and then psychotic disorder was about 10%. Other studies have found a very similar estimate of the presence of psychotic disorder in adults with autism spectrum disorder. So when I'm assessing someone for anxiety, who is presenting with aggression or agitation, I'm looking at different components of their experiences, which can set off agitation or anxiety, agitation or aggression if they were anxious. And of course, for example, with those with autism, yes, of course, they have difficulty with changes in routine. And so when I'm referring to changes in routine here, I'm referring to not just minor or, not just, big changes in the routine, like going in and out of a school break or having someone visiting or traveling. I'm talking about really minor everyday changes in routine, such as having a substitute teacher that day, or having to drive a different way home because there's construction, or parking in a different part of the driveway than what the individual is used to. As far as transitioning between activities, once again, with autism, that is part of autism. So what I'm referring to here is beyond that. It's particularly helpful when that activity that they're really struggling with, and it will have a large outburst. It's particularly helpful when that activity is a preferred activity. So for example, for a child who might go to Hard Fixin' and loves to go swimming, and they have a very nice pool there that's warm water. And so they love to do that. But every time they're supposed to go to the pool, they have a big outburst in the classroom, even though once you get them into the pool, they can't get out. So that's making me think that they're really struggling with that beyond not wanting to go to the activity. Separation from a caregiver. So like getting on the bus, which also involves transition in the morning, or the caregiver leading and they're at home. Interrupting and obsessive behavior. Once again, that's part of autism, but when it's really intense, you're giving them a 15-minute warning, a 10-minute warning. It's going on to a desired activity, and they're still really, really struggling with that in regards to causing aggression, agitation. And then, of course, situations that evoke fear. And when I bring this up, I encourage you to think about what may evoke fear for that individual. Because just because it may not evoke fear for us, for that individual, based on their own life experiences, it very well may evoke fear. For example, if they have history of trauma from a male caregiver, they may really struggle with future male caregivers and get really upset, even if those caregivers are wonderful and very caring, and that doesn't change that person's experience of fear associated with that. Sensory stimulation, with a grain of salt. I realize I'm getting a little bit outside, in particular, of anxiety. I can say that when I see kids really struggling, or adults really struggling with getting overstimulated in typical environments, like going to the mall or going to the restaurant or just going out in public, I'll throw that into here, even though it's kind of squishy. That's why I put the question mark. And so, when any one of these lights up in the history, I will ask about the rest of it, because any one of these alone would not make me think that person is anxious. Rather, I need to see a few of these come up to make me think that this agitation or this aggression could be in part related to a manifestation of anxiety. So depression. So the thing about depression is that it happens to you. So unlike anxiety, which I think of as kind of a wiring thing, I mean, I think, even though anxiety may ebb and flow, an anxious kid, often you can date it way back, to very early childhood. Mood disturbances are different. They happen to people. There's usually a previous baseline. So if there's agitation that starts, even if it was like 5 years ago, it started 5 years ago, you want to establish a baseline from before that started. And then ask about these depressive symptoms, because everyone is their own norm. You can't just use a neurotypical person to be a norm. For that individual, before the onset of their disruptive and the agitation, what frequency was their crying spells? How much did they enjoy activities, and what activities did they enjoy? What is their interest in being around others? Many of these folks don't want necessarily to be around others, but at least they're interested in sitting down with the family to eat dinner, or being around the family, or going on family excursions. Like what was their interest in being with others? And then what were their eating habits and sleeping patterns? And then fast forward to where you're at, and then look at each one of those and how different is their presentation in that regard with these different depressive symptoms, as well as other depressive symptoms, compared to before the onset of the agitation. And that also helps you with is, if you do feel that depression is there and it's worthwhile to target, that also lets you know what specific symptoms are you anticipating on seeing improve, as well as the disruptive behavior. Like, what are you targeting? Are you capturing what you are intending to target? And then, could this be bipolar disorder? And when I refer to bipolar disorder, I'm not talking about rapid cycling. I'm really talking about discrete periods of time. So it's an episodic experience, not an ongoing experience. And this episodic experience has to last, for me, at least 2 days. For the DSM, it needs to last at least 5 days to call it, if you haven't initiated intervention. But for me, if they go at least 2 days, 48 hours consecutively in a distinctly different mood state from their baseline, and it occurs not related to an exciting event, not related to a change in their environment, but entirely out of the blue, then that will get my attention. And if that's the case, then I will ask about these discrete periods of time and ask about the manic symptoms. So yes, their agitation may be doing this, but now I'm going to ask during these times, do you see a decreasing for sleep, increased energy, laughing for no reason, increased vocalization? So for those individuals who don't have language, they still will often vocally stim. And for those individuals, when they're experiencing a manic type episode, you will see an escalation in the frequency, in the volume of that. And then are they sexually acting out? Once again, different than baseline. This is for those who don't sexually act out at baseline, but acting out during these periods of time. And then, like I said, DSM-5 requires at least 5 days to, call it hypomania. From my perspective, I will target it from a treatment perspective if I can at least see 48 hours. And usually when I see at least 48 hours, I will see, 3, 4, 5 days, if not more. But for me, I will target it very aggressively. And so, like I said, it can't be rapid cycling. It has to look like this, but I will use about a 48-hour threshold to say, yeah, I think this is a cyclical mood disorder. I need to target it as such. And then ADHD, I don't start here. ADHD is very common in those with neurodevelopmental disabilities. In fact, it should, the attention and behaviors do need to be, put in the context of that person's developmental level anyway. And then beyond that, you see a high degree of impulsivity and hyperactivity and attention in this, in general in this population. So I don't start here because, first of all, many things can look like ADHD, sleep disturbance, mood disturbance, anxiety, like all of that can. And so even though I'll kind of just collect, a list of symptoms, I definitely don't start my target here until I've ensured the others are doing better. And if they're doing better, then I'll reassess to see if those symptoms are still there. Along those lines, if you are having issues with anxiety, sleep disturbance, mood instability, then by all means, I will need to treat that first before I try to target ADHD, as I will be ineffective at targeting ADHD until the rest of this is in place. I just want to tip my hat to the behaviorists and the therapists there as I talk a lot about medical stuff and psychiatric stuff and medication intervention. It does not replace by any means therapy. I think it coincides nicely with therapy. In regards to behavioral analysis, I work really closely with someone with the BCBA up at HMHI because it is so important to identify what is perpetuating that particular disruptive behavior. Because if a behavior is dysfunctional behavior is repeatedly occurring, even though it's dysfunctional for everyone else, it is likely serving a function for that individual. And so once again, getting back to those ABCs, what's the antecedent, what's the behavior, what's the consequence? Because as I am trying to address the mental health condition that's setting that person up for using this behavior to manipulate their environment, I see myself as addressing the need part of it. If they are terribly anxious and they're desperate to try to regulate their anxiety level by having various behaviors, then I feel like I need to reduce that anxiety such that when I can get it from a need to a want, yes, they will always prefer to have some, to do various things. But if I can get it from a desperate need to a preference, then I feel I can set them up to be successful, in particular for the interventions that the behavioralists have. Similarly, I'm going to have a hard time getting it from a need to a want in intensity until it's no longer being reinforced. And so working hand in hand with behaviorists to think about the ABCs of that behavior, to what degree does this mental health condition fit into this, and how can I reduce the intensity of that experience for this individual so that changing the trigger circumstances and inadvertent consequence is in place as well to collectively try to get this person to making better choices in these circumstances. And so we just talked about this, but recognizing, removing, reinforcing, and consequences of disruptive behavior, recognizing the antecedent and offering more appropriate alternative, and then figuring out what's precipitating the antecedent, and that's where the mental health issue comes in, and then addressing that along with changing the dynamic of that behavior. So really asking yourself, what are you treating as you're addressing persistently disruptive behavior? So the roadblocks I see to patient-centered treatment of agitation, and so I'm talking about like a medical intervention. As you can see, many of these individuals are on psychiatric medications. Many with just severely disruptive behavior are on antipsychotic medications as well as anticonvulsant medications in the absence of a seizure. So that means it's probably being used behaviorally. So already there are meds flowing. And even though the caregiver knows that necessary information to identify what's causing the agitation, they often don't realize the relevance of this knowledge. And then even though the medical providers know how to treat these common causes of agitation, when you saw that list of, the differential diagnosis, the providers know how to treat that. They just don't know, they don't have the time in their 10-minute visits, and they don't have the expertise to know what to ask to then put it together and go, oh, this is depression, this is anxiety, this is a mood disturbance, this is sleep disturbance. They don't have the time or expertise to put that together so that they can then initiate the treatment that they often know well in their neurotypical patients. So these are, I think, really big roadblocks that cause the type of prescribing you saw earlier. And so that's really where the sources of distress came in. So back in, I think it was around 2017, mid 2017, I had been giving lots of lectures, in our community about, this mental health concerns, physical concerns in this population leading to agitation, how to address it. And I would see some changes in our prescribing in the community. And I would also see providers go back to kind of that knee-jerk antipsychotic prescription when, during crises. And I'm not saying that's wrong because they need to contain it. It's just, I'm also saying it's not going beyond that. They're not then going, okay, what caused that? And so as I was moaning about this to one of the parents that I see regularly, who happens to be one of the co-founders for the Autism Council of Utah, she said, well, don't teach them, teach us. We're the ones who really care. And that's when it occurred to me, because I was thinking of putting together this tool that the providers could use to learn how to ask these questions. And then it occurred to me that you're right, they are the ones who really care. I mean, of course, the medical providers care about their patients. The mental health providers do, but they have a short period of time, and no one can doubt just the dedication of these parents and these caregivers. And yes, they really will spend 15 minutes to complete something if they feel this could help their child get the care they need. And so I ended up developing this tool, not for the providers, but for the parents and caregivers. And so it is for them to complete, it's for them to access. And the items are based on behavior manifestations, similar to what we just discussed, that are from the diagnostic criteria, and common physical comorbidities it will query as well, so that you could understand that bigger picture. It's been validated in focus groups, including parents and professional caregivers, and then affected adults with language ability who could give me feedback. And then it was reviewed by experts in neurodevelopmental disabilities, and it's copyrighted by the University of Utah. And so this is that, list of all the things that, like I said, this is your differential diagnosis for agitation. And when I bring this up to providers, I just want them to realize with this tool, this may take a lot of time and expertise, but it doesn't take your time, need to be your time and your expertise. And what I really think about this tool is that when I would do this interview, when I would do ongoing care with patients and see them for the first time and do this interview, it would take me 45 minutes to go through this differential diagnosis. And it was like going through Candyland. I was like, just kind of like making my all these questions, making your way all the way, around here to get to the point where you have a sense of what's going on. Because like I said, I don't treat agitation. I don't chase agitation. I treat the condition that's leading to the agitation. And so what this tool does is it gets me right here, and it gets the providers right here. So not only does it save me 45 minutes, it saves the family 45 minutes, because really, I don't know what my problem is. Like, it really takes me 45 minutes to go through these questions. And yet families can get through this easily in like 15 or 20 minutes. And it uses branching logic. So they're not asked all the questions. Like no one gets all the questions. They're just asked the questions which are relevant based on their previous response. And so it saves them 25 minutes. It saves me 45 minutes. It also, I have it programmed. It's in REDCap at the University of Utah, which is HIPAA compliant. And I was able to program a report generator. So I click a button and then the whole report is just generated. So I copy and paste that into my note. And then it saved me another 30 minutes of like typing away. That report generator, by the way, is down. It's been down since the early spring, and I'm desperately trying to figure out how to get it working again. What is not down is the sources of stress. That questionnaire is still out there. It works great. The parent caregiver interface is the same as always. It's just my end is I am generating these reports from handwrite now, and I'm looking at various different ways of trying to find a way around this. But anyway, so it's definitely still in use. And I've been pursuing various different things. So right now it's saving me 45 minutes of history, but not necessarily the documentation part. And so this was made possible through a grant from the Autism Council of Utah. And of course, the University of Utah Health was able to lead to sources of stress. And then it had been used in our community for 2 years. And the Department of Health and Human Services, Department of Health at the time, was hearing of its use. DCFS was using it, DSPD was using it. And so they asked why we didn't have a public link. And then I explained, well, I had asked the university to have a public link, and they said they didn't want to have the liability associated with a public link. I mean, it was free. It's just the provider had to reach out to me, and then I would send them a specific link for that individual. And so when I brought up, well, the university didn't want the liability, so I have to do it that way. They said, we're not worried about liability. We'll host the public link. And so they contracted with the University of Utah and the Huntsman Mental Health Institute through the Registry of Autism and Developmental Disabilities. Simply from a contract perspective, the data doesn't flow by any means in this direction. It's rather just because I'm PI of the registry, it fit nicely from a contract perspective. Now since September of 2021, the BCSHCN website for autism services has hosted this free link that any parent caregiver from anywhere can access. And so when they access it, so they'll fill out just very basic information with their email, and then to that email then goes a link for that sources of stress. That way you've got that double authentication. And then to that email, I will send the report. And if I see anything in there that I think I could be helpful with, I've yet to see one that I haven't felt I could be helpful with, I will offer to speak with that provider. I can't speak to the parent. I don't have the bandwidth, and that's not my patient. Their child is not my patient, but I am happy to do a curbside consult with that provider and discuss with them the parent concerns and their understanding of their patient. So collectively we can put some working diagnosis together, and I can offer them suggestions in the treatment plan. And so that happens over the phone between the provider and myself. And then I will give the provider my cell phone number. And for really complicated individuals, we'll often just schedule another time to talk, like in 4 weeks, just to do an update, because there's a part B and C to the plan. But also just, they can reach out if things become more problematic again, and they can get additional support. So when I'm treating these conditions, so first, like I said, you have to identify what it is that you're treating, and then you treat it. But many issues will come up when it rains, of course, for these folks, particularly once it's risen to the point where it's affecting everyone around them. Like I said, they will suffer alone for so long, and then they just can't anymore, and that's kind of like bubbling up out of the surface. So sleep disturbance, that is at the very top. If they have a sleep disturbance, that is the very first thing I do, is I treat that. But it's what's causing the sleep disturbance. And so if it's bipolar, if it's mania, if it's fear, if it's environmental, like whatever, we will do a full court press on the sleep disturbance based on what's leading to the sleep disturbance. And once they're sleeping, then if they have a cyclical mood disturbance, if that's still a problem and they're sleeping, I will target that more specifically. And once they're sleeping and they're not having mania and their psychosis if present has resolved, then I will look to see what's left in regards to anxiety, depression, PTSD, and target that. And then once they're sleeping and they're not manic and they're not psychotic and their anxiety and depression and PTSD are reasonably treated, then I will look at ADHD and I will reassess to see, well, what does the ADHD symptoms look like now? And if still quite prevalent, as many still have them quite prevalent, then you can treat it. The part of this is because the medicines which treat ADHD are, the medicines which treat ADHD better than anything else are stimulants. That is true for neurotypical individuals. That is true for those with developmental disabilities. The problem is that those with developmental disabilities are less likely to tolerate it. So it doesn't mean you can't go there. It's just they're less likely to tolerate it. So you want to set them up for success. Also, I know providers feel differently about this. Just having spent most of my days taking people off stimulants, I can say that by the time I'm seeing them, it's unlikely they're going to tolerate a stimulant because of all their other issues. I will not use stimulants in someone who has a history of bipolar disorder or a history of psychosis. Like, it just never, ever will not do it. But that's me as a provider. However, for those who are anxious and depressed, I may reduce the stimulant or take it off if these are really problematic. But once I've gotten on top of this, I can reintroduce it very carefully and just keep a good eye on it to make sure that keep it at a lower dose, keep a good eye on it, make sure we're not making this worse. And the other nice thing about knowing what you're treating, rather than just kind of throwing something against the wall like a medicine to see if it sticks, is since you know you're treating, you know what you're chasing besides agitation. And so you can go ahead and have a parallel process. So when you see medical conditions, by all means, treat them. So if there's constipation, if there's pain from whatever, like, treat that. That doesn't need to be by itself. You can go ahead and do that and treat these issues too. You can have a parallel process in treating these things because you know what you're treating and you know what you're specifically following up on to see if you've gotten good treatment response rather than just looking at the agitation. So medications can cause side effects. It's not unusual. We call it in medicine iatrogenic. It's not unusual. I will see iatrogenic causes of agitation. I mentioned the stimulants. It can set off just about anything. Anticholinergics cause constipation. And so, realizing, and then this population, I think, are much more prone to constipation. Antipsychotics can cause this internal sense of restlessness, like akathisia. Unfortunately, the two that have FDA approval to treat agitation in individuals with autism are notorious for akathisia in this population. And so you have to keep an eye on that. That's Risperdal and Abilify. But any medicine that's an antipsychotic can do this. And then the other thing too is when you stop the medicine or take it down, it will then cause withdrawal akathisia, which will worsen it before it gets better, which just is another issue on its own right. Antidepressants, I definitely will use antidepressants to treat depression or anxiety in an individual who is not intolerant to them, they haven't tried it before, and in an individual who does not have bipolar disorder. I would just go really low and really slow. Because 30% will get disinhibited or have a manic switch, but that just rescued 70% from an antipsychotic. Just be very cautious and very, very slow to make sure, because the lower, I will find a response to really low dosages, very unlike I will find any response to it in a neurotypical person. So you go low and you'll not only see the side effects at lower dosages, but you'll see the true effects. And so you want to capture those true effects. Benzo certainly can cause disinhibition. And then, of course, some of the anticonvulsants are notorious for this, although very powerful. So it's really about trying to find that right balance and working with neurology to figure out how to help these individuals and making sure that they're not experiencing seizures, particularly those which could be life-threatening, and yet be on a regimen that they can tolerate emotionally. So the sources of distress, so I did this data cut back in like May or June of 2020. And at that time, 231 individuals had completed the sources of distress. 151 had an accompanying informal or formal consult. So we're just going to talk about what I found there. And these are individuals who are presenting with agitation. And I'm getting pulled in as a consultant, but these can be in the hospital. These folks can be institutionalized. This can be involving DCFS, DSPD, emergency rooms. A lot of primary care folks will reach out, neurology, other specialty cares will reach out. So it's a broad group of folks across Utah and some beyond. 68% were male, and their mean age was about 19 years of age. So about 2/3 were less than 13. I'm sorry, 1/3 was less than 13. 1/3 was about 13 to 22, and then about 1/3 were older than 22. So across the lifespan. Almost half had limited or no use of words. 85% had autism. So very, very high co-occurrence. 11% had some genetic condition that had been identified. 68% were already taking antipsychotic medication to treat the agitation, which was not working. And 30% were on anticonvulsants to treat the agitation because they didn't have a history of seizures and it wasn't working. And I think my point here is it's for those individuals, like, it's not that I just stopped the antipsychotic. I definitely didn't do that. It is calming and the people were in crisis. Rather, there was a reason why the antipsychotic wasn't working. And over half the time, it was because the underlying cause of the agitation was actually due to a medicine that they were also on because no one figured out what was going on that was causing the agitation, and they didn't realize that medicine was contraindicated for that condition. And so the antipsychotic or the anticonvulsant never had a chance to calm those individuals down. And worked much better when those medications were stopped. And then of course, also there's obviously other conditions, like I was saying, that need to be addressed medically to help them feel better. So what I found, and this is just screening, so screen positive status. You can see a high screen positive for anxiety. Once again, this is a treatment-resistant, agitated group of individuals with pretty severe neurodevelopmental disabilities. This is not an epi study of the prevalence of these conditions in those with neurodevelopmental disabilities. And this tool should only be used in those who are experiencing distress. In fact, if they're not experiencing distress, the person completing it will be told that, if they can't indicate a manifestation of distress, then they're told this tool isn't meant for you to fill out. So high anxiety, high mood disturbance, by the way, these are mutually exclusive groups. If they had depression and mania, they went here. If they had depression without mania, they went here. These are screening. This is screening. And then PTSD, ADHD, not surprising. Psychosis is screening really high. I'm going to circle back to that in a moment. But any condition was, almost 100%. Now, subsequent diagnostic impression. So then when I did an informal, formal consult, or members of my team did a formal, informal consult, this is what we found. So I want to show you big jump down in depression. A lot of these folks, instead of depression, were diagnosed with either mood disorder, unspecified mood disorder, or disruptive mood dysregulation disorder. I don't have an algorithm for that. And so that's what I'm working on right now to add that into this. But also you can see a big jump down in the psychosis. So it cast a very broad net, which it's supposed to, but you've really got to then get clarification, understanding, and in reality, it was about 20%. Also, these are the medical conditions. And not only are these present, but these were conditions that the parents felt were contributing to the distress. So yes, these occurred, but they would not be up here if the parent then didn't feel like they were contributing to this distress. You can, like this is just among the females, but I mentioned earlier, about 40% of those who are female families felt menstrual issues were related to the distress. Not surprisingly, gastrointestinal issues, but you can see the other issues, and any medical condition was over 70%. Contributing. So important to think about these medical concerns that are co-occurring with the behaviors, co-occurring with mental health conditions, and all the stress going on in that individual and their family's lives. So the big picture is that agitation is a final common pathway for several different problems, and identifying and treating, that treatment target, and it's plural. I can't think of when it's just been one thing. Is really the way I approach reducing that agitation, and it's effective and it's as safe as possible. The psychiatric meds I feel should be targeted towards a specific psychiatric condition rather than agitation, because those who are started on antipsychotics, there are studies that have shown that they will be on them indefinitely. They are not just on them for a short period of time. They will be stuck on those for a long, long time. And so I will reserve those antipsychotics for bipolar disorder and for psychosis because it's indicated. And I will use them as secondary or third line, for anxiety, maybe for depression or something else, if that individual was unable to tolerate or respond to those first few lines of treatment, but I just don't start there. And then it's so important to tap into the knowledge of these parents and caregivers, the professional caregivers, especially for adults who live, you know, in homes outside of their family's home, so that they can have that adult relationship with their parents. And those professional caregivers, just like parents, are the key to understanding what's going on and to establish that differential diagnosis. I haven't gotten interrupted yet. Does anyone have any questions? So I could tell you the case. I'll also be doing the case presentation today, and so for the case presentation, we're going to go through. We're going to talk about an adolescent male whose mother completed the source of distress. So we're going to go through it so you can see it, and then talk about how that fit into his care. And I also, there's a couple of questions there that I want to tap into your knowledge on as well. So Rachel, do you usually should I just jump into that, or or do people need a break?
You can go ahead. We usually just jump right into that case.
Okay. All right. So I'm going to stop that share. I'm going to pull up the case. Okay. Let me share this. Okay. So Rachel, can you guys see that? Okay, so great. All right. Okay, there we go. I used your template. Okay. Right. So we're going to talk about Johnny. Johnny is not his first name. That's his alias. But I can't, but I need to use a name to talk about this person. So he's 13, white male. He lives with his parents and his older brother in a Utah town on the Wasatch Front. He attends a specialized school for children with autism. And he has an incredibly dedicated team of parents. His pediatrician is amazing. And he has worked with the DSPD emergency support coordinator, who is also amazing and an incredible advocate and a dear support for this family. He is on the waiting list for DSPD services. And this support coordinator, this emergency support coordinator, contacted me because he had been putting holes in his family's wall. They have plywood up throughout the house. He's been very agitated. He has had severely self-injurious behavior, and he's been up all night, and this poor mother and father are exhausted, and she reached out to see if I can be helpful. So his mom completed the sources of distress, and this is what the first page looks like. So this is the arrow. This is templated. This is templated. This is templated. This right here in this box is specific to Johnny, but these are check boxes. So the caregivers asked, does your child manifest these symptoms of distress? And so these are the boxes that they checked, and they're also given an opportunity to check others so they can put additional things. And I can tell you self-injurious behavior had not been on this list until the first 6 months I've been using this tool, and I kept on seeing self-injurious behavior listed as other. So it is now on this list in one of the check boxes. And this is specific, of course, to Johnny. But most of this is templated. And then now from here down, this is specific to Johnny. So he's 11, he's 13, and he has a phallage language ability. He has limited use of words. His mom described his diagnosis as autism. That's what she knows he's diagnosed with at all. He clearly has intellectual disability as well. And his primary care doctor, his pediatrician, has been working really hard with him to try to stabilize these behaviors using fluoxetine, Prozac, Risperdal, and clonidine. I will point out what's notable here. So he is on an antipsychotic. He's on just so you know, 3 milligrams of Risperdal for a 13-year-old is a very robust dose of Risperdal. And he is still not sleeping, and he's still really agitated, and he's still pulling. It's like, so something is off. Like, this should do it. This will do it for anyone. This will do it for someone with autism. This will do it for someone without autism. Something is going on that is keeping this Risperdal from working, because it should be calming him regardless of what's going on. So his experiences are disruptive to those around him. And so at the beginning of the source of stress, you can see I ask about the ABCs of the behavior. For Johnny, the trigger mom has identified as food. If he gets told no, or he can't have something, he will throw a fit. And then when I ask about what may be reinforcing this behavior, what may be motivating it, I ask about attention seeking, avoiding a task or demand, or trying to get a desired item. And his mother endorsed all of those, as well as the fact that sometimes he just seems to be upset. Like, he doesn't even know why he's upset, but he's upset. And this occurs at home. With his sleep, he wakes up, he falls asleep at 9, but when he wakes up at any point in time, it could be 3 o'clock in the morning, it could be 8. It's very erratic. He generally gets about 3 to 6 hours a night of sleep. He doesn't take naps, and he does wake up in the middle of the night. This has been for multiple years as far as his difficulty falling asleep. And when he, instead of falling asleep, he has trouble falling asleep, but he also is waking up in the middle of the night. And what he does when he is waking up is self-stim behavior or using electronic devices. And he will have periods of time lasting at least 2 days of decreased need for sleep that don't have any antecedents to no, just seem out of the blue, and he snores. So as I look at this part, this is clearly a trigger for him, and it's important for me to realize this because he's on Risperdal, which is probably making this worse. This is also important to understand what could be reinforcing this behavior, and there's a lot of things here that you could imagine someone with a behaviorist expertise can be really helpful with. Yet there's other things going on here, as if there's this kind of like, ocean surge in the background that's going on that seems to be happening to him, that just, cause him to be agitated for, and it just it's not even clear why. This is very notable, 3 to 6 hours a night. This is not enough sleep. There is something that's interrupting his sleep. And this is problematic for him. He is not experiencing restorative sleep, nor is his family experiencing restorative sleep, which is just going to cause that snowball to go rolling downhill further. And he is having periods of time out of the blue lasting at least 2 days, so 48 hours of decreased need for sleep. Now the anxiety section. So these are the pertinent positives. So you're not seeing the pertinent negatives. And so you can see issues related to transition. When it comes to getting stuck on things, because I knew many of these folks would have autism who completed it, I put a higher tier to it. So not only do they get stuck on things, because that's what you see with autism, but it needs to cause very significant disruption or discomfort, which it is for him. Similar with the hyperfocusing, that's part of autism, but it needs to cause a significant disruption or discomfort, and it is for him. And then there's panic, and then he has a lot of sensory sensitivity. And you can see how his mom really gets it. She understands that when he's in crowds, that's what makes it hard for him. That's why he's saying bye-bye, go home, is he's trying to avoid the sensory, why he's covering his ears. He has no history of trauma. For depression, he has crying spells. He has increased irritability. He has loss of interest in things he used to really enjoy, and he's got the self-injury. And he bites his hand, and his mom does think that can be a source of discomfort for him. So he has anxiety, I would call it, as well as depression in addition to a sleep disturbance. So for mania, I always start with asking, the tool asks, what is this person's baseline level of energy? And for him, it's average. That's very important, because when you're asking about a period of time lasting 2 or more days, in which they have a distinctly different baseline, you need to have them be thinking about what that baseline is to begin with, because it has to be different than their baseline. And then if they do have 2 or more days when they have a distinctly different mood state, they're asked if this is out of the blue, or if this is related to exciting events, or changes in environment. And if they say it's out of the blue, then they're asked about the manic symptoms. Otherwise, they're never asked about manic symptoms. And so for him, he's laughing and he's for no reason, very happy and giddy for no reason, more risk-taking, less sleep. And then ADHD, he's got lots of ADHD stuff, but like I said, I don't usually start there. And so, yeah, I would say that he has bipolar disorder. When I did talk to mom, this isn't just 2 days. This is lasting 5-7 days, sometimes longer. Yeah, he has ADHD, but I would need to circle back to that later before I targeted it. Once I've gotten on top of the other stuff. He doesn't have any symptoms of psychosis. And from a medical perspective, he has these intermittent bowel movements that his mom feels is leading to distress. He is having a bowel movement once a day. I would not have been, flagged on that one. Even the intermittent bowel movements wouldn't have flagged me, or the variable bowel movements. But what's flagging me is that mom thinks this could be leading to distress. So I need to understand why. No dental issues, and mom says that he's very sweet, and she's just talking about this, he just gets into these states and he just spirals, and he can go from like laughing, being really happy, to like then starting kicking down the walls and being destructive. So that's the sources of distress for Johnny. These behaviors primarily start in the afternoon, and they will continue to escalate into the evening until he goes to sleep, which you can imagine why it's particularly problematic that he often doesn't go to sleep soon. They will occur sometimes in the mornings on the weekends, but still mostly in the afternoon and evening. Although his mom is consistently told by his special needs school that he's doing well there, curiously, they started the My Way program for him a few months before my consult. So it does make me wonder if maybe it's not going as peachy there. Maybe it is. But regardless, he certainly does better in the school setting than at home. So my primary areas of concern are his sleep disturbance, secondary to bipolar disorder, that's also provoking the self-injurious behavior. And now he has a hand injury, secondary to that, that's probably perpetuating that. He definitely is anxious. He has autism and intellectual disability and an inability to communicate what's his feelings, his thoughts, his needs. He has a history of severe constipation. He currently has variable bowel movements, and this is concerning his mother. And so it's definitely something I'm going to put a pin in regards to, as we progress through treatment, if we're just not getting to where we need to go, we're going to revisit that. And see if maybe he can be backed up. And that's why we're seeing these variable bowel movements, because you can see diarrhea, what looks like diarrhea, as secondary infopresis is what it's called, where you are backed up and you have this big clump in your rectum of stool, and then the liquidy stuff is kind of escaping around the outside and coming out. And then his appetite changes, is definitely fueling his behavior, and these are being exacerbated by, I'm sure, one of the medicines he's on. So the reason, so the Risperdal should have been treating this problem. It should have treated the bipolar, but he was on fluoxetine, or was it? Yeah, he was on fluoxetine 40 milligrams. It never had a chance. It's just not, it can't compete with, the mood stabilizers can't compete with the effects of antidepressants, and they can't compete with the effects of stimulants. And so when you have one of those on board and an individual has a bipolar presentation, you can throw all the mood stabilizers you want to, and it is very possible that you will not stabilize their moods until you stop stepping on the gas with those medicines that can exacerbate those problems. So my primary goal is to stop the suffering. And thinking about what I just presented, so sleep disturbance, which is caused by his bipolar mania, I'm going to start right there at the very top. And he really, he could benefit from therapy in the home to help create a structure that will be meaningful to his mom and worth putting effort points into. And then, of course, treat the medical conditions that, so if, and he ultimately was backed up and had constipation, and we did do a clean out, and that definitely helped the medicines work better as well, as him feeling better and sleeping better. And so we treated so he has a fantastic pediatrician. And so I reached out to the pediatrician, and so the pediatrician did this as I helped coach the pediatrician and work with the pediatrician. And he treated the self-injurious behavior wound, and then that resolved. And with the intervention for mood stability, his self-injury did not return. His food instability did continue, and so the plan will be, once his sleep is normalized and his self-injury has resolved, you can try to cross-taper the risperidone to another antipsychotic that treats bipolar, but with less appetite stimulation. We tried, we failed. The bipolar came back, and so we've now had to target that bipolar with other medications to capture that bipolar. So he really does have a pretty persistent mood instability that we are now on top of, but it's required a pretty aggressive full court press. What I really was hoping was to be to extend his ABA that he was receiving at school to the home setting. That just did not happen, and we'll talk about that in a moment. And then, like I said, keeping an eye on that constipation. Ultimately, we determined he was, and we cleaned him out and started the musher and pusher. The musher is the Marilox, the Sen is the pusher. And when you work with this population, you need a musher and pusher to get their bowels going if they have trouble with their bowels. So for you guys, what I was really hoping to get your feedback on was, so this family was really struggling as soon as he would get home, even on the ride home from school. Already his mood is escalating, because you will see that with bipolar disorder. You will see mood escalating in the afternoon and then evening. And then, of course, there's the food part of it that then escalates things. He's a large kid to begin with. And we really tried to figure out how can we get the school to provide behavior supports at home. And even though the school is receiving all these insurance funds, for the behavior supports, that was not what they did, is provide behavior supports at home. And so the insurance money was all taken up by the school, but not there for behavior supports at home. And then this kid needed to be stabilized in the hospital. He really needed to be stabilized in the hospital. This is ridiculous that we had to stabilize him at home. He was flooredly manic. And we had to do this, these changes in medicine, and we were never able to access the hospital. Even though I was helping with his family, and I obviously have connections with HMHI, the hospital was full. They were full. They already had a waiting list of like 6 weeks for those patients that were in the home program. This patient was not in the home program, let alone someone who's not in the home program. He could go to another hospital, to the emergency room, like maybe, just maybe, he can get admitted. But then, those providers don't necessarily work with me. And so they would not know what to do, nor may they be interested in my recommendations on what to do. And so that probably wouldn't have been very helpful unless it was in a setting where the provider was willing to work with me, which I would be happy to work with them. It's just psychiatrists can be like herding sheep sometimes, herding cats sometimes. And there are definitely programs in the community where I have great relationships with the psychiatrists who work there, but that definitely isn't a given, and you just don't know where you're going to get sent when you go to an emergency room, if you do go anywhere, which often doesn't happen. So I'd love to, so first I just wanted to kind of just express my concern about access to inpatient care. This family had to do more than what anyone should expect of them to stabilize this child at home, and to kind of get your sense of what you've run into in the community, and then also just what you've been finding as far as getting funding supported when all the insurance money is going to a school that isn't supporting the home setting. So any thoughts or suggestions, or having similar experiences?
Dr. Bilder, this is Jamie. I'm curious, with the behavior supports that are going towards the school, so there's no other ABA supports that they can access through Medicaid or anywhere else?
Yeah, so no, that's a great question. I think they have Medicaid, because I think they would have been eligible. They live an hour away from the home program. And so, but but they just expressed willingness to go to the home program. And actually, but they have this fantastic pediatrician. So it's like, well, let's see what we can do here. So, but I bring it up because if that were an option, it meant that they had to have Medicaid. But I'm wondering if, so the school is a school, I assume that it all went to the school. Because the emergency support coordinator was looking for funds to try to support, and ultimately, she worked her magic and was able to find some funding to have an outside behaviorist come in. I think that, and they did come in, but it took a really long time. And I wonder if that was more related to her just ability to just, kind of squeeze a turnip and get juice out of it. But it definitely, it seemed like the school had, it was a full-time school. So I assume they just exhausted all that money. What have you found, Jamie? Have you found that the schools don't take all the money and then insurance will give more money for after school when these schools are getting money from the insurance for care?
I think, well, and I may have this wrong, but I've always thought that the school, they've kind of segregated their care. So what they receive and what they do stays within the school. But state Medicaid should be paying for ABA services even outside of the school. And I know they just passed that, I don't know if it was a Senate bill or House bill, to provide ABA services for adults at this point who qualify for autism. So maybe looking into that and seeing if that's an option.
Now, do you think that would, so I'm so glad you brought that up, Jamie. It is great to see they created the Autism Treatment Fund, the adult Autism Treatment Fund, and then they funded it this last year so that these young adults can access treatment. But that's just for adults, isn't it?
If you have Medicaid, you should be able to access ABA services, assuming you qualify for state Medicaid. And I'm so sorry, I'm just about to get my booster shot, so I'm
no, go ahead and jump off. And so so what I'm going to do, I'm going to reach out to the emergency coordinator because I'll have to reach out to the emergency coordinator because does anyone understand how those schools work? Because with the specialty schools that help kids with autism, I know that they get money from the Carson Smith bill. But I guess I assume they were also getting money like to have it entirely covered because the Carson Smith only pays for some of it. Do you know what the limits are? So for Medicaid, does anyone know what the limits are in this for how much AB? Oh, sorry.
So I work at, it's called UW Behavior Services. So it is actually a specific organization that works with kids on the autism spectrum. And how it works here is, and again, I don't know if he's going to public school. If he's not going to public school and he's coming to something like UW Behavior Services, then usually, I mean, it depends on the insurance, but they're probably limited to 30 hours a week. So if they're using all of that for the 30 hours a week of ABA to come here, then that doesn't leave anything for in-home services in the afternoon. So again, not saying that this is actually how it works. If he's going to a public school, obviously it's going to be different.
Thank you so much for
30 hours a week.
Yeah, thank you very much for that. So I'm thinking he was exhausting that 30 hours at his school. And that's why there wasn't anything else left over. That was the sense I got, as well as the Carson Smith. But I will definitely circle back to the support coordinator who is doing emergency services. Oh, so can you, who is it who just, oh, it was from UBS? I don't have the, can you?
It's Alicia Holmes.
Oh, Alicia, thank you. So thank you, Alicia, for jumping in. Can you speak to, so for UBS, when these kids come in and you do the education and teaching and supports, how does your school work when these kids invariably have behavior issues at home? What is usually available, especially for those who are receiving 30 hours and getting their education through you guys?
I mean, I think that's the problem we run into, that we get 30 hours a week. If they really want in-home services, we would maybe try to do it during the day. So,
yeah.
But I think that is exactly the problem that we're running into too, where they have exhausted that and then they go home and they're kind of on their own. And
right.
Even me, like, I don't know what other services are really out there. We'll
right.
work a lot on like respite care and things like that, but actual ABA, there's really nothing else once you hit your maximum.
And then how about you guys, what are you finding? I know that it's just, I know inpatient care in our community is just so limited for these folks. And I know that the developmental center is just got funding to have an acute behavior track there. And right now they're, looking at staffing it up to try to give some access to the community for active treatment, for those with who have mental health conditions and need to be on an inpatient unit but can't access it and can access it in that type of setting, and then return to their home or their community home. But it just continues to be, I know, a challenge. That's sad. It's because these folks have these disabilities. They just can't access this care because of the amount of resources that are needed within these hospital settings to care for them safely. And then subsequently, so for every bed, like at HMHI, for every bed that has someone with someone like Johnny, they would have to say no to 6 neurotypical individuals. So the staffing resources required to care for Johnny would be the staffing resources that would then cause them not to be able to bring in 6 neurotypical folks. So it's easy to kind of point fingers and go, you need to do a better job. You need to fix this. In reality, it's not just one cause of the problem. There's multiple aspects to this. So does anyone else have any other thoughts or ideas or questions?
I have never used the sources of distress scale before. I thought that was really great information. I'm also curious if anybody else here, whether you are more mental health or disability services, have you run into a situation before where you think using this tool might be helpful for you in the future?
So I have a question about how you're getting this information out to parents, because I didn't know about this tool and I'm in contact with a lot of parents. So I just wondered, how have you a plan to get this out to parents?
Thanks, Janet. Good to see you again. It's been a while. Right now it is on the Autism Services website. Like I said, freely available. And so that's the Bureau of Children with Special Healthcare Needs website for Autism Services. There's a link to this tool. As far as advertising it, gosh, I wonder, I'll have to reach out to the Autism Council of Utah to see if they advertise it on their website, since they're very aware of it. I will find I have a son who has autism, and so I'm on the Facebook group Big Macs, which I love. I get the best ideas from other moms. And when on occasion, when I'll see a mom talking about, the concerns that they have for their child, that just looking at the description makes me think, gosh, I just wonder if this could be helpful for them. It seems like it's a mental health condition. I will actually then just as a mom, just say, have you thought about completing the sources of distress, and put a link to the Autism Services and just say this is freely available and it was funded by the Autism Council of Utah. And so that's kind of your starfish throwing in that regard. And so Janet, I would love to get ideas from you on, how do we distribute this information, because it was developed for parents and professional, it was meant for you. The whole idea, I mean, there is no such advocate like the advocate for a parent of a kid with neurodevelopmental disabilities. Like, they're very powerful. And the idea is, though, they have this report, it's written for them, and then they can bring it into their provider, so that when they're going in, because the child's often already on medications, they can discuss these issues that we now have words to about, and how this might be going on with their child, and then what would we do specifically for these concerns. And then, like I said, also, I'm always happy to talk to that provider. So it's really intended to really enhance that shared decision making between the parent or caregiver and the provider.
I can help get that out to some of my parent contacts, but just another question related. So how are you getting the information to the medical professionals to be prepared for this? Because if a parent just walks in and the doctor doesn't know anything about it, are you doing anything in that respect?
Yes, so I've done a couple talks at critical issues. So there's this critical issues conference here in Utah that invariably is held, I think, at the Hilton downtown or something. And it is for mental health providers and in primary care providers, and those who are and other service providers for kids and adolescents with mental health concerns. And there's a number of individuals who also are involved in other aspects of kids with neurodevelopmental disabilities who will attend as well. And so I've given lectures there on the provider tracks to introduce this tool. And so it will get used that way initially. And this still happens, but initially, what will happen is DCFS will have gotten involved, DSPD will have gotten involved. Like I would get kind of pulled in by another agency, and then they will, they would reach out to that provider, and the provider is like, what's this, and then, so then they'll look at it, and then we'll talk about it and offer recommendations. And then what I'll find is that, a couple months later, they'll reach out to me. I was just thinking, I saw this other kid in my practice and they kind of remind me, and, and I wondered if this could be helpful for them. And so then I'll find that they'll then start thinking about who else in their practice for whom this would be helpful for. And they'll have them complete it. And so I've kind of got these little nodes around the state, of folks who are just really comfortable with it. And so it's not unusual where a provider kind of gets pulled in very unexpectedly, okay, I'll talk to this lady, whatever. But usually I feel like it goes pretty well. We right the ship, and help these kids do better. They're much more effective in the efforts they've put forth. And I'll find them then kind of multiplying in a sense, and then considering this for their other clients.
And I see Ashley's got a hand raised.
Oh, yes, Ashley.
Hi, Dr. Bilder. I do have a question because I want to be respectful and mindful of the amount of work that goes into this, that report that you prepare and the note that you prepare for families. If we are to share this more widely, is that going to significantly impact your capacity? Do we need to consider that?
So Ashley, so Ashley, I totally get it. And I appreciate you asking that question. So this has been out since 2019. And I could tell you, so I'm a pediatrician as well as a psychiatrist, and as well as a psychiatrist. And and I'm in my ivory tower at the University of Utah, like at Huntsman. And I appreciate that. Like I get that. Like I appreciate that because my mom was the first ever pediatrician in the rural county I was raised in. She was so busy that we would take as a family vacation once every few years. It'd be very hard for her to find someone to cover for her practice. I think that's why it was so infrequent. And I saw what that life looks like. She was on call every single night, 24/7. So I know what that looks like. And so I feel like if a primary care provider has time to talk to me about their patient, I can find the time to talk to them. And I can tell you that these primary care providers are very efficient. They will not reach out unless they need help. I feel very comfortable giving them my phone number. I've never gotten an inappropriate text or phone call. We can usually get through it really quickly. In fact, they're very helpful and they structure me very well, or I would take forever to get there because I'm very kind of ADHD and all over the place. And so when it comes to the report, so that's the part. So that was with an automated report. I don't have an automated report. Instead, I use these mocked up reports. So it takes me about 10 or 15 minutes. This is slowing me down. I am working right now with REDCap and trying to decide when I'm going to throw in the towel with REDCap because I can't get where I'm trying to go, and try something else. But I feel like that's my problem. I will figure this out. And I have a team. I can hire someone on to help me with this. I can get the support I need. So if this becomes overwhelming, I know where to get support. I know where to pull more people in to help me. It will get me to get this operationalized that much faster and find someplace besides REDCap if that's what the answer is. So don't hesitate to use it. Really don't. And I received the Presidential Endowed Chair for autism research and clinical translation, I have resources. This is one of the things, talking about creating a much more sophisticated tool that the provider can engage with as well, to get kind of automated basic recommendations that would typically accompany this, rather than me being in it. I mean, that was part of kind of my pitch, you know, when I was applying for this job. So don't worry about overdoing it. That will prompt me to reach out and say, okay, now I'm going to hire someone to help me with this, and to figure this out so that we can meet this need of the community.
That was a great question, Ashley. And Debbie, I love that you are so committed to this and passionate about this. I think this is a wonderful tool. And I'm excited to see if anybody that we have here today is able to implement this or share this with someone who is able to use it and make a difference that way. So I'm very excited about this.
Thanks. And if you guys have any more questions, just feel free to email me. And I know we're at the end of our time. Amazing. You guys made it an hour and a half. That's pretty good.
Yeah. All right. Thank you so much, everybody, for coming. Thank you again, Debbie. I am so glad you were here and were able to present. So appreciative of that. I will get all these materials typed up and summarized, and I will put them on our Canvas page. Thank you, everybody. Feel free to send me an email also if you'd like to connect with Debbie or if you have any questions.
Bye.